Hello, everyone. We are just going to give a few minutes for people to come in. We apologize for the late start. We had a few technical issues. We will begin in 1 minute. Thank you for joining us. So good afternoon, everyone. My name is Tamara Winfrey Harris, and I am the president of Women's Fund of Central Indiana, where we convene, invest, and advocate to ensure that everyone who identifies as a woman or girl in Central Indiana has equitable access to opportunity to reach their full potential, no matter their place, race, or identity. So last year, you may have heard, we completed the most in-depth community listening, landscape analysis, and organizational assessment in our history to develop a bold new strategic plan, which we will drop in the chat. But one of the things we heard from you is that you wanted more low-cost opportunities to really engage with issues that are critical to women and girls. So I am thrilled to invite you to the second of 3 hourly virtual community conversations that we will host this year to hold space for issues that matter to women and to girls. And this session, we are so honored to be joined and to partner with the Circle City, Indiana chapter of the Links Incorporated. And I am pleased to introduce Deborah Oates, chapter president.
Thank you, Tamara. Links Incorporated is one of the nation's oldest and largest volunteer service organizations of extraordinary women committed to enriching, sustaining, and ensuring the culture and the economic survival of African Americans and other persons of African ancestry. The Circle City chapter is part of the international network of Links Incorporated, nearly 300 chapters in 41 states across the US, the District of Columbia, and the Commonwealth of the Bahamas. Our founding and guiding principles are friendship and service, and we are devoted to serving our local communities with specific focus that has to deal with many of the facets that we are involved with. And one is the health and human services. We're also involved with services to youth, the arts, national trends and services, and international trends and services. And so we are concerned about the health and the well-being of women and their families. And so we know today's conversation is a very critical one. So today we're going to talk about weathering and maternal health with a focus on the early health deterioration caused by social or economic adversity, and political marginalization, weathering, and its impact on infant and maternal health in our communities.
So Deborah, I'd like to add, share a few statistics with our audience. So we know that the United States has the highest infant and maternal mortality rates out of any other high-income country. According to the National Institutes of Health, Black women in the United States disproportionately experience adverse pregnancy outcomes, including maternal mortality, compared to other women in other racial and ethnic groups. We heard about this last year at our Power of Women event featuring Allison Felix, who we know has her own experience with difficulties during pregnancy, and one of her teammates on her Olympic team also sadly passed away last year in childbirth. So preterm birth rates are high in Marion County and have actually worsened in the last 3 years in Hamilton County. In Indiana, the infant mortality rate for non-Hispanic Black infants is 2.5 times higher than that of non-Hispanic white infants. And disparities were seen in the 2023 maternal mortality report between non-Hispanic Black women and non-Hispanic white women in maternal health outcomes. So for Black women, they experienced 28 pregnancy-related deaths per 100,000 births, compared to over 15 pregnancy-related deaths by non-Hispanic white women within a 4-year study period. So the National Institutes of Health has also noted that historical legacies of institutionalized racism and bias in medicine compound the problem of infant and maternal mortality. And obviously there's a term for this, and it was coined by Dr. Arlene Geronimus, which we were thrilled to help bring to Indianapolis last year. Weathering, again, is the early health deterioration caused by social or economic adversity and political marginalization.
Our expert panel today is going to help us better understand infant and maternal mortality in Central Indiana and the impact of weathering. They will share their experiences on the front lines of women's health care and the work to ensure women and their families can thrive. Dr. Lindsey Weaver was named Indiana State Health Commissioner by Governor Eric J. Holcomb on June 1st, 2023. She brings to the role a passion for improving the health of Hoosiers through a focus on prevention, data-informed programming, and access to care in all corners of the state. Prior to her appointment, she served since February 3rd, 2020, as the Chief Medical Officer for the Indiana Department of Health, where she helped to lead the state's pandemic response by spearheading the development of the statewide lab testing network to expand COVID-19 testing capacity in Indiana and led the statewide distribution of COVID-19 vaccines and therapeutics. And we hope that Dr. Virginia King will be joining us. So let's talk about our next panelist. Deborah Draper, Community Health Supervisor, has been a community health worker since 1990. She has over 30 years experience working with mothers in high-risk zip code, pre-pregnancy and post-pregnancy, removing barriers so that moms have a safe and healthy pregnancy and delivery. She has worked at Eskenazi Health with their Health Start program, a supervisor with Reagan Street, and now with the IU Health We Care program.
Thank you so much for joining us today. And thank you everyone who is here online with us. So I wonder, Dr. Weaver, if maybe you can start us off by telling us, shaping the story about maternal and infant mortality rates in Indiana, and then in Central Indiana specifically.
Hi, everybody. Thank you so much for having me today. So we have just recently here in the last month put out our maternal mortality review committee report. So that would be a report on all of the maternal mortalities from 2021, even though just now came out. And then we just came out with our infant mortality rate and report for 2022. So that just came out in the last couple of weeks. Those are both available on our website. It dives down into the data as we analyze and look at, what were the causes, disparities and differences, including location of residence of the mother for both for infant mortality. Thankfully, our maternal mortality, it's still really small numbers. And so we're not able to provide that much level of detail for that in order to, of course, protect people's information there. But as much as we can break it down, I think the other thing to recognize with the maternal mortality review is that because they're small numbers, it's difficult to find trends. We don't have enough data to say, are things going up or things going down? Looking at specific numbers, we just haven't been analyzing it for that long. It is frustrating to me, I will say, in my health commissioner role, that to me, this data is old. I worked really hard throughout the pandemic with our data teams here so that we could provide as close to real-time data and information to Hoosiers and also to entities who were utilizing that data on a day-to-day basis to make decisions. And we want to do the same with our infant mortality data for sure, and then also work on our maternal mortality data. For the maternal mortality data, we have a whole committee, a large group of people who review every single mortality and look for themes within that information and where there are opportunities for a change. And unfortunately, 2/3 of those deaths were determined by that group to be preventable. Something else important is you'll see Indiana ranked with maternal mortality on some national reports. And I just always want to remind people is you really can't look at that. Unfortunately, with maternal mortality, everybody looks at it differently and talks about it differently. So it is not comparing apples to apples for us to compare to a state. All we can do is utilize the data that we have here. We had 80 deaths in 2021, and those are pregnancy associated and pregnancy related. So pregnancy associated would be death from any cause while they're pregnant and up to a year after delivery. Pregnancy related means they died from something actually related to the pregnancy. And we had only 14, but that's still a big number, 14 of those deaths in 2021 that were actually related to the pregnancy. And we definitely see disparities there when we look comparing, non-Hispanic Black women compared to non-Hispanic white, disparities on insurance, disparities on how many prenatal visits were made, et cetera. And like I said, we get down into the details in that report. And I think something I always want to mention of those 80 pregnancy associated, that includes if they got in a car accident 9 months postpartum, if they overdosed 6 months postpartum, and actually overdose, intentional or unintentional, is our highest number one cause of maternal mortality. And looking at infant mortality, so again, 2022 data, so a little bit closer in time, but my team for the first time ever was able to announce preliminary 2023 data this year. And we're pretty close, it's right to the right number. We've been seeing our infant mortality rate go up over the last several years. And in 2022, the US infant mortality rate went up for the first time in over a decade. And we followed that trend. We also went up at that time. But our preliminary data for 2023 saw us go back down. So we're hopeful that that is the trend we're actually going on. Everyone believes that infant mortality went up across the US and also here. We believe in Indiana was associated to still some of the effects from the pandemic. People not seeking care, not having as much access, right? We know that a lot of our primary care providers and even our OBs really had to kind of restrict, abilities to access and, changes in insurance and just the whole world in general, we believe are some of the leading causes of that increase in infant mortality. So we went up to 7.2 in 2022, and then our preliminary is 6.5 infant mortality rate. That's out of 1,000 babies in 2023. But to note, the US was at 5.6 in 2022. So we definitely are higher than other states. We have a lot of work to do there. And we're continuing to work with our partners here in Central Indiana and across the state to be able to address it. It's a lot of information, but I think it's good to kind of have that background, what we're talking about and so a little bit about what we're doing.
So when we talk about the fact that Black women and their children have higher rates of mortality and complications, and again, that's across socioeconomic groups. What contributes to those disparities? Deborah, in your experience, your 30 years working in this space, what are you seeing?
Well, I think a lot of the things that contribute would be the homeless, unemployed, single moms with multi-children, no support and no education. And they have to figure out what they need to do in order to live, in order to make it to the next step, in order to go to the doctor, once they are pregnant. So society and everything that they have to do in order to keep their lights on first and feed the kids and make sure everyone's fed. And then moving forward to their doctor's appointment. Medicaid, sometimes it takes 30 days, 60 days, and they feel if they don't have insurance, they're not going to be seen. So all those things contribute as one as a whole. Transportation definitely is a big issue. We use some of the transportation systems, Medicaid cab, it doesn't show up all the time. They don't have money for Uber now or Lyft, so all those things. And also, when they get to the hospital, they don't like how they're being treated because you're 4 months pregnant and you haven't been here. So they feel some kind of way. They want to have a healthy baby, but they have other things that come first. You got to have lights on. You have to have food, and every mom loves their baby and want to have a healthy baby. But the situation and the system that we have here definitely is broken, and we need to have a lot of work to do to get it fixed in order for them to have a healthy baby.
I think that, Deborah, I love that you talked about the fact that there's certainly a lot of structural factors that make it difficult for mothers, especially if they're living in poverty, difficult situations. But there's also the idea of sometimes mistreatment within the medical health care system, because we know that, again, hearing from Allison Felix, hearing from Serena Williams, talk about how when she realized there was a problem during her pregnancy, she almost died because she wasn't being listened to. And so, are there ways that, one way to solve that would be to make sure that medical personnel are culturally competent and don't have biases? But are there other ways that you recommend that mothers, Black mothers, and all mothers are able to advocate for themselves? Or is there advice that you share that helps them to advocate for themselves when someone isn't listening?
Yes, ask to speak to someone else. Say, this is what I need. This is how I'm feeling. Something's wrong. If you're not going to help me, please let me talk to someone else. Or if you still feel that you're not being served, I tell mom, go to another hospital. You keep going until someone listens to you if you're having an issue and something's going on. Because they'll be like, well, you ain't been here in 4 months. You're 4 months pregnant. Okay, but you don't know what I'm going through, but I'm here, so help me while I'm here. Don't, so teach moms to just talk up. It's okay to speak up for yourself because no one else is there to do it for you. If no one's listening, go somewhere else. Someone is going to eventually listen. Someone we know, that has the time, will take the time to see what's really going on and want to help you. So, and moms think, well, I got Medicaid, I only can go to one hospital. You go to as many hospitals as you can to see what's wrong with you and your baby. Don't worry about that because I want, tell them eventually if you get a bill, we'll figure that out later. But you need to really go. They say, well, I'm not going to be seen. It's going to take too long. That's not continue to, speak up for yourself. And we have to as African American women. So.
I see that someone helpfully may have dropped in the chat a link to midwife and doula services. Do you find, Dr. Weaver or Deborah, do you find that women that have someone extra to advocate for them and support them, do we see better outcomes in those cases?
I would say yes, because that doula midwife is educating them in the process, as well as we trying to educate them on their body and what's going on and all of that. So, and they're educating them on all the different for it's going into labor, if you want an epidural, if you don't, and all those things. So yes, it definitely helps. Because the more you know, the more you know, the smarter you are as a mom, and you can have a healthier baby.
I don't have the data at my fingertips, but I do believe there is data that supports that having a doula available improves outcomes. I will say, you know, as a practicing ER physician, any additional advocate in the room helps. I think that means, you know, we do a lot of things educating the mother, right, to try to advocate for herself. But I think it's important that we need, you know, their husband, their partner, their mom, their aunt, whoever's going to be with them also to know. I mean, I even think about people, you know, you can get preeclampsia and eclampsia after you deliver. We often will see cardiomyopathy problem for delivery, and the mother may be unaware that she's, you know, maybe acting differently. She doesn't know, right? She's postpartum. And so we need to rely on those other people in their circle to help recognize that something's not right here. And then I often hear when moms come in and they're sick, you know, even before and they have to have a baby, that they're too focused on the infant to worry about themselves, and they had to really be kind of pushed to come in. I always think, well, how many moms were they not able to convince that they needed to be seen, and then it was too late, right? So it's really empowering their whole circle to speak up and say, hey, something's not right here. I know this person, and things just aren't really matching up. I will say that we're working to help with that access and that advocacy. My Healthy Baby is a program that we have now statewide, just of last year. And it's a home visiting program. And part of that is to educate the mom, educate the family, make sure that they have access to resources if they need help with transportation or whatever it may need, both before delivery and then after delivery, which I think is just as important, right? The majority of our mortalities happen after delivery. And that's something important that I think people need to remember and pay attention to. That's now in all 92 counties for women who are eligible in those communities. And My Healthy Baby helps connect them to that home visiting program. And then we're also seeing what else we can do to help support doulas and access to doulas across the state as well.
So, you know, one of the things that Dr. Geronimus suggests in her book is, again, it's the constant weathering of being part of a marginalized population. And in her book, she talks about, you know, not just Black women, but also immigrant populations, Appalachian populations, people living in poverty. There is an ongoing weathering grind to your health. Which is why some of these disparities, cross socioeconomic lines. But I wonder if there are things, Deborah or Dr. Weaver, that we can tell, you know, women of childbearing age and, you know, Black women of childbearing age. Are there things that we need to be thinking about to take care of ourselves if we know we want to get pregnant and if you want to have healthy babies? What are the things we might be doing to maybe mitigate some of those stresses and prepare our bodies for a healthy birth?
Well, through the We Care program, we always have moms who are thinking about getting pregnant, so we tell them to start taking vitamins, keeping all your appointments, making sure you get checkups and all of those things, eating right, you know, sleeping, just getting your body ready as well as your mind. Because having a baby affects body and mind, all one thing going together. Just early education on, you know, different things. Food, eating, keeping appointments, taking vitamins, getting everything ready to have that baby, the process of getting pregnant. So just trying to educate them on all of that. So when they do get pregnant, they know what the next steps are, but they're healthy and ready. So that's definitely what the We Care program. We definitely have moms who are wanting to be, so we just help them. And we also tell moms who have just had their baby to wait at least 2 years to have another baby so your body is ready, you know, physically and everything. So to be at the best health that you can be having another baby, you know, at least 2 years apart at the most. So.
And I'll just add that our data supports that. So the leading cause of our infant mortality is perinatal risks. So that is basically an unhealthy mom, right? So that might be substance use. It could be uncontrolled, diabetes or some other risk factor. Obesity is also a risk factor to have preterm babies, which then increases the risk of infant mortality. So those are all things that can be addressed before a woman is ever pregnant. So, making sure that if you have underlying health conditions, that they're controlled, if you are suffering from substance use disorder, that you are connected to treatment, that if you're smoking, you stop smoking. Looking at our infant mortality rate, 8% of white women were smoking. The numbers are lower in our non-Hispanic Black and are not in our Hispanic populations, but 8% is a high number, and we know has risk for preterm and low birth weight babies. So there's a lot of opportunity to help save moms and save babies way before there's ever a pregnancy.
I just want to remind everyone that's watching, if you have a question or a comment for Dr. Weaver or for Deborah, to please drop it in the chat or the Q&A so that we can share it with them. And I see folks that are dropping some really great resources in the chat, and we will be sure to capture those. We always send out a video of this discussion afterwards, and we will try to capture some of those resources in the email that comes out later. I wonder, Dr. Weaver, because we talked about, one barrier to healthy births, particularly among Black women, is, how systemically, how we are treated by doctors in ER rooms, those kind of things. Is there a movement within medicine to try to make sure that the people that we might deal with are culturally competent and don't carry some of the biases that we know exist about us, feeling less pain and, some of those things, to make sure that when we walk into a hospital or somewhere looking for care, that we get equal care? Is there any movement within the medical industry to do that?
I think personally in the medical field, but I've also seen in public health, absolutely there is a movement in that direction. And I think, you brought up the immigrant population earlier. I've been working with a couple of different health departments here in Marion County and then Daviess County, who have had a high Haitian Creole population, and learning about their discovery process of cultural differences and how they're helping address and navigate that with those populations is really great. And I will say the cultural differences has had some adverse effects on some outcomes. And so they, are learning, and they're doing the best that they can do better. I can't imagine, being pregnant, about to deliver, and then being in a brand new country where nobody speaks my language and trying to navigate this very complicated system. And I think that there are some things that we can do. But yes, I have seen a movement and an increase with our learners as well, right? I mean, it should start in nursing school, medical school, et cetera, to have cultural competency. So, and that's been throughout, my 15-year career, an increase in that. I did want to mention some work that we're doing is that, we know that the best decisions and help is coming from the local level, that our locals, like I mentioned, Daviess County, they know what their needs are of their community. And so we've had some really intentional work from the State Department of Health. They've, now 87 of our 92 counties have opted into increased public health funding through Health First Indiana. And our maternal child health team has reached out to our 10 counties that have the highest zip code infant mortality rates and are helping them dig into the data. In some instances, they were not aware. Marion County is very aware. They have epidemiologists, they have data analysts, but we have to remember some of these other communities have they may have 3 people working in their health department. And so we're helping them connect them to the data. And then they know who's the best community-based organization, who's trusted in our community, is it a faith-based person? Is it a, or entity? Is it another community-based organization? Connecting with them so they can start to address, what they see there at the local level. And I think that's where we're really going to see differences, is when we are intentional about where the support, the programming, the funding, the people, all those things are going.
I believe, and I am so glad that it looks like we have been joined by Dr. Kane, which is wonderful. Dr. Kane is the Director and Chief Medical Officer of the Marion County Public Health Department. She's an Associate Professor of Medicine at Indiana University School of Medicine Infectious Diseases Division. In 2020, the IBJ named her as one of 40 influential people of the last 40 years. She was awarded Governor Holcomb's 2021 Circle of Corridon Award for service. She recently received the Moselle Sanders Foundation Reverend Roosevelt Sanders Humanitarian Award, and throughout the COVID-19 pandemic and still today, she remains responsible for the overall safety and protection of Marion County residents. She is president-elect of the National Medical Association and was recently appointed as a member of the CDC's Board of Scientific Counselors, Deputy Director for Infectious Diseases. Welcome, Dr. Kane.
Well, thank you, and I apologize for being late, but I'm still having technical difficulties, and it's unfortunate, but I can't seem to be able to get my camera to work, and so I'm hoping to get another laptop to replace that. But thank you so much for having me here.
No worries, Dr. Kane. We are glad to have your wisdom here. And I wonder, so we're deep into this discussion about what maternal and infant mortality looks like, and Dr. Lindsey Weaver helped shape that for the state of Indiana. I wonder if you might share a little bit about what you are seeing in Marion County.
So our infant mortality rate actually went up from the year 21 to 22. So we were fortunate enough to be in the lower 7.8 in 21, but actually went up to like about 10.4. And the goal for 2030 for infant mortality, by the year 2030, we should be at 5. So we were hoping to try to see if our infant mortality rate could be low, at least below 7. And what we're seeing, which is no surprise that we're seeing across the Indiana and even across the nation, is our Black infant mortality rate is actually twice the rate of our white counterparts. So our infant mortality rate in 22 was like almost about 14, though we had gotten it down to 11 in 2021. And so one of the issues we've also seen is that our Hispanic numbers they're sort of like in between. So our lowest infant mortality rate are with our white mothers at about 7.1, and our Hispanic mothers are like at 7.8. But we still are having difficulties getting in our people of color into the first trimester of care. So, excuse me 1 second, I apologize, 1 minute.
And what it sounds like is Dr. Kane is echoing what we heard from Deborah Draper earlier, as we talked about some of the things that are contributing to poor health outcomes, is that lack of access to good care.
So one of the key things is that if you don't have at least a minimum of 6 prenatal visits, and they have to start in the first trimester, you don't get adequate care. Our number 3 causes for infant mortalities, number 1 is low birth weight, or you're preterm. So that baby is born at a smaller baby. A lot of times they end up in the neonatal unit. The number 2 cause has to do with birth defects. And so moms, if they don't start their prenatal vitamins in the first trimester, that baby doesn't have the opportunity of benefiting for being on those prenatal vitamins as the number 2 cause. But we also see a significant amount of SIDS deaths, sudden infant death syndrome, which we know is highly associated with smoking inside the homes. But we also have a lot of babies that can be in a crib, they're placed on their stomach, and they can smother and suffer from suffocation because they don't have the ability to move that head. You know, if a blanket should adjust against their nose and they asphyxiate. And so we have to teach our young mothers that they need to place their babies on their backs in order to cut down these deaths related to those three things. But it's unfortunate, some of our other factors is sepsis for the mother, because some of these mothers have group A strep, and we have to check for that and treat that, you know, before their delivery, or otherwise the mothers can get a infection inside their bloodstream that can be life-threatening and cause their deaths. And so the younger the mother you are, the age of 18 and less, are the ones who are most likely to have a delay in getting their prenatal care. And so it's almost 30% of them, easily 30 to 40%, do not get their prenatal care until the second and third trimester. So it highlights that we have a lot of education we need to do for our adolescent young moms and those moms that are 18 to 21 years of age.
Thank you.
Yeah,
But-
just one last point I want to make. Latino and Hispanic women, they don't get into their prenatal care that early, but they have an advantage that Black African American women don't. And that is about 91% of Latino mothers breastfeed their babies. And so they're able to provide mothers maternal antibodies to protect that newborn baby for 6 months. And for Black mothers, we're at a low, just almost barely making 70% for breastfeeding. So we have a lot of work cut out for us.
So I want to kind of shape what I think I've heard from the three of you, you know, thinking about things that may help us improve some of our numbers. I'm hearing access to care and early access to care and respectful care that is culturally competent, and, you know, medical providers that listen to women, including Black and brown women. It sounds like making sure women are healthy and taking their vitamins, and, you know, their bodies are prepared, and especially focusing on women who may be living in poverty, making sure that they get that same access. And someone asked in our Q&A, they said Flint, Michigan has launched a guaranteed income program that addresses poverty and postpartum support. Have there been any discussions of a similar program in Indiana, given our high maternal mortality rate and childhood poverty rate?
So I honestly haven't heard of a similar project like that here in Indianapolis. I don't know, Lindsey, are you aware of that program in Flint, Michigan, where they're assuring them of a income for pregnant mothers, I guess all the way through postpartum?
I was not aware of that program, and I haven't heard anything here either. I mean, they did expand Medicaid coverage for 12 months after delivery, so that's recent, but not this income program.
So no, we'll have to really have to check on that.
Yeah.
I wonder, because we are edging up very closely on at 1 o'clock, but I'd love to hear from each of you if there is one thing that you think we can focus on that will make a difference in our infant and maternal mortality rates, and specifically also the rates for Black women, since we know Black women and Black babies have disproportionate outcomes. What would that be? And I'll start with you, Deborah.
I would say transportation, maybe using something within the hospital system. Like Dr. King said, the first 6 visits, maybe you getting the hospital in social work or whatever, getting Uber or Lyft in programs somewhere where those moms can have at least those visits. Without transportation, you don't have it, you can't get there. So, like I said, we only have so much of Medicaid cab, which we can't count on to a certain degree. It's not 100%. No money for Uber or Lyft. That would definitely be, I would say, one of the most important things.
Dr. Weaver.
I think for me, the big lessons that I learned from the pandemic, and then as we're like continuing to push it in the infant and maternal mortality and health space, is that, you know, kind of broad sweeping one size fits all programs just don't seem to work. And I think it is, I mean, we talk about this all the time, taking time to you know, communicate with people in the affected community, learn from the moms who have lost a child, learn from the families, you know, talk to the clinicians that were engaged, you know, with those patients as well, to really get down to the bottom of it and then address it there where it's happening. And I think that my hope is, at least from my perspective, that we can help support that from a data perspective, working with our locals, working with our hospitals, being intentional around that work. And then, you know, if it's not working, pivot. Don't try to do something for 5 years and not see a change and continue to do it, which I think is something we've done for a long time. So I'm excited. I'm just looking to be more proactive. Thank you.
Dr. Kane.
This is such a tough decision. I think it's just so critical that we've got to get our women in early for prenatal care, that we can't wait for them to finally make it in the second and third trimester. And I agree wholeheartedly. We're working now to try to get Lyft or support as transportation for some of our pregnant mothers. And I do think that's critical. But I think we really have to do a much more major campaign, especially for our younger pregnant mothers, to get them in early for prenatal care. And I'm hoping that with the assistance of doulas, that will be more encouraging and more of a motivation for them to keep their prenatal visits. I think that's going to be a critical tool in terms of addressing this infant mortality than we have had before.
If I can add something, Dr. Kane reminded me, I think we also need to recognize that this is not just OB providers, that all clinicians, anybody in the clinical space needs to be engaged here. When I'm going out and about in the state, I remind people it is also often the emergency department that quote unquote diagnoses the pregnancy, right? So what are we doing right then to ensure that that person gets into prenatal care, right? There's nothing keeping us from going ahead and doing their screening tests, right? Their HIV, some blood work. I've encouraged everybody to add syphilis to that. We've seen there in 2012, we had 0 congenital syphilis cases, and we are over 40. I mean, it is for a year, and that is 100% preventable. If we diagnose the syphilis case and treat the mom, then that baby, I mean, one, it increases your risk for stillbirths, and then of course, you know, lifelong problems for that baby, and that's going to take all of us, right? It's not just the family doctors and the OBs, it's the ED docs, it's the urgent cares, it's you know, wherever that woman may interact with our system. When we go back, just an example, when we go back and look at those congenital syphilis cases, maybe they didn't get prenatal care, but they have touched our system, whether it was an emergency department or a substance use disorder facility, a recovery facility, one of our state agency facilities, whether it be DCS or WIC or somewhere, right? So what are we doing to be where people are at and use that as a way to get them connected to, like Dr. Kane said, that early prenatal care. Sorry, that's my soapbox that I forgot that I have.
No, thank you so much. Thank you, Dr. Weaver, Dr. Kane. Thank you, Deborah. Thank all of you and everyone. Oh my gosh, there was such a robust conversation happening on chat and in the Q&A. Thank you for everyone who contributed resources to help us improve maternal and infant health outcomes for women in Indiana and in Central Indiana specifically. Victoria.
Yes, thanks again. Just echoing for being with us this afternoon. Thank you to our panelists. We hope that this programming has been helpful as you think about this issue faced by mothers, or many issues as we've talked about here in the community. Please mark your calendar for our next community conversation at noon on Thursday, August 22nd. And as always, please support the Women's Fund. Your financial gifts help us to alleviate the $1 million a year Women's Fund must raise to support the administration of our grant making and community leadership and programs like Options, Executive Women of Color, Leadership Program, Night of 100 Women, and other initiatives. We really appreciate you and all that you do to make others and to make our community better for women and girls in all the ways they show up in the world. Thank you so much, everyone.
Thank you.